Last question for this particular case. Anybody want to tackle just defining, if we're considering chemoimmunotherapy with FCR, what's the genetic profile, the molecular profile that that patient should have? Just so we're clear, if someone's going to get FCR, what's ideal?
So it would be a young patient, typically less than 65 years of age, who has mutated IGV8 genes and a low-risk FISH profile, such as deletion 13q or trisomy 12 or a negative FISH, and an absence of a TP53 mutation on a next-generation sequencing study.
I would say that, so based on the ECOG study, the immunochemotherapy for that particular group of patients is not inferior to ibrutinib, but it's also not superior. So the progression-free survival were no different. So I guess for those group of patients, you could consider either or. But for the rest of the patients, ibrutinib has outperformed immunochemotherapy combination, right? So that's the definition. I also want to bring back this patient's particular profile and mention something that's interesting. So remember, this patient has a IGVH mutated status, and it has 11q deletion. And we know that from conventional immunochemotherapy studies, patient with IGVH mutated status tends to have a worse treatment outcome compared to those with mutated patients. But when patients were treated with ibrutinib, the subgroup analysis from the RESONATE-2 study, which I mentioned first, that's the ibrutinib single agent versus chlorambucil. So if you just look at the patient who were treated with ibrutinib and look at the subgroup analysis of those patients who has mutated versus unmutated IGVH, there's actually virtually no difference in the progression-free survival. So it looks like the ibrutinib has been able to negate the negative effect of the IGVH mutated status. And for 11q deletion patients, even more interesting. So for patients who are treated with ibrutinib, we know that 11q deletion patients, when they're treated with chlorambucil, they tend to do worse compared to those patients who don't have 11q deletion. But it's actually the opposite when they were treated with ibrutinib. So those patients with 11q deletion seem to have a better progression-free survival compared to those patients who does not have the 11q deletion when they're treated with ibrutinib. So those adverse prognostic factors may no longer be adverse when patients were treated with ibrutinib-based therapy.